Good morning. Thank you for joining us today for our first event in the Health Equity Series for 2022. We're super grateful that you're able to join us, and we're looking forward to the great conversation about data and health equity. Again, thank you so much. And Lucas, do you have?
Yeah, we want to go first to Kate Brummie, MassChallenge's acting CEO, to kick us off. So Kate.
All right, good morning, everyone. Welcome. I'm really pleased to be here this morning to listen in on this such important topic, and also to briefly introduce MassChallenge for those of you who may not be familiar. MassChallenge is the global network for innovators. We believe in a stronger future through collaborative innovation and are proud to work at the intersection of startups, industry, government, and academia to power entrepreneurs solving massive challenges. We have a decade of experience now directly supporting high potential, high growth startups accelerate through the often treacherous early stage by connecting them to the resources, expertise, and network that our experience and research have shown are essential. We do this work proudly at no cost and for no equity to ensure that we can work with high impact, high potential startups, regardless of whether they fit or break traditional venture molds. We've now worked with over 3,000 startups who have gone on to raise more than $6 billion in funding. We estimate 80% of startups remain active, which is more than 4 times the typical rate in venture. We also have a decade of experience now working to enable high potential innovation, make a difference for industry and government in order to strengthen and accelerate important outcomes. Perhaps never has this mission and this work been more urgent than the work that we're doing within the healthcare system to improve outcomes for patients and save lives. We launched MassChallenge HealthTech just about 5 years ago now, specifically to help cross the chasm between small startups and large established players in order to accelerate important innovation, reducing cost, increasing access, improving outcomes, looking to connect startups, seeing the future and creating solutions agilely with the players who could help them develop and scale. This year, we're extremely proud and very fortunate to expand on this mission through a unique partnership with HHS through the launch of Pandemic X. Pandemic X is a first of its kind collaboration between MassChallenge and the Department of Health and Human Services. Through this program, we're working with 15 startups intent on addressing health equity specifically exposed and exacerbated by the pandemic. These startups are here in this program working with us and HHS to gain access to key stakeholders and resources, develop strategic action plans to grow. And while the goal of Pandemic X is specifically linked to health equity, this is a theme that we've now brought central to all of our work in healthcare through our HealthTech portfolio. The Health Equity Series, where we are today, has been a critical part of learning and championing this key aspect of healthcare. We've been at this now for just about 3 years. And one of the key takeaways from last year was the importance of data. This is exactly why we're starting off 2022 with a series on the role that data plays in health equity. So before I give another thank you and turn it over to our key partner at HHS, I just want to do a quick advertisement of our upcoming health equity events, which we hope you'll join. We have Health Equity in Government on April 20th, Health Equity Internationally on May 24th. And the registration link for those events will be sent in the follow-up, so stay tuned. So now let me conclude with a huge thank you. This work is not done by MassChallenge alone. It is thanks in huge part to our partners at HHS and also across our MassChallenge HealthTech universe. With that, I'm delighted to introduce Stefan Konya, MassChallenge HealthTech Board of Advisors member, and perhaps more importantly, co-lead for Pandemic X and senior advisor to the Deputy National Coordinator for Health IT. Stefan, welcome.
Sorry, I had to unmute there. Thank you, Kate, so much for that outstanding opening, and also for the kind words about working closely with HHS. And I'm honored to be one of the lead individuals who gets to work closely with the MassChallenge HealthTech community. I work for the Office of the National Coordinator for Health IT, and in my role as Senior Advisor and Innovation Portfolio Lead, I get to work with accelerator programs throughout the country, incubators, and others who represent and support the innovation community. We're excited that through the Pandemic X initiative, we're able to work a little bit more closely with specifically MassChallenge HealthTech in their HealthTech vertical, focused on specifically addressing the issues that were exacerbated through the pandemic. Now, this is a unique, one-of-a-kind type of initiative for HHS. We've got 7 federal agencies participating in it that include the CDC, the CMS, ACL, and many other agencies, FDA, and of course, ONC and OASH serving as the leads for the initiative. We're excited to work closely with those 15 startups, but really with the entire innovation community that MassChallenge HealthTech helps to bring together, especially when it comes to the topic of health equity. One of the reasons why Pandemic X was chosen to work with MassChallenge HealthTech was because of the fact that they put a focus on health equity into all of their work. The fact that they put in a anti-bias training program into the selection of which startups get into the cohort, and making sure that application reviewers have a chance to consider some of the potential biases they themselves may have as they're selecting which startups should qualify for the cohort, was something that I thought was highly admirable, and something we should look at embodying into many of our programs when we're trying to select who gets into which programs. So we're also excited for the Health Equity Series. In fact, so excited, you'll see my boss on the panel here shortly, Dr. Nikki Tripathi, who is the National Coordinator and the Senior Health IT Advisor for the administration. So with that, I'm going to go ahead and turn it over to the illustrious moderator for today's panel, Dr. Dee Dee Ray, Director of Data and Analytics for the New York City Department of Health and Mental Hygiene. Dr. Ray?
Thanks so much for having me here today. I really appreciate all of the investment that MassChallenge has taken into promoting health equity and innovation. And I think now we can maybe introduce our other panelists. So if Dr. Tripathi and Dr. Pierre, if you want to put your cameras on. And so I think we heard a little bit about Dr. Tripathi already. He's the National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services, where he leads the formulation of federal health IT strategy and coordinates federal health IT policies, standards, programs, and investments. Dr. Tripathi has over 20 years of experience across the health IT landscape. He most recently served as the Chief Alliance Officer for Arcadia, a healthcare data and software company focused on population health management and value-based care, the project manager of the Argonaut Project, an industry collaboration to accelerate the adoption of FHIR, and a board member of the HL7, the Sequoia Project, and the Commonwealth Health Alliance, and the Karen Alliance. Dr. Tripathi also served as the President and Chief Executive Officer of the Massachusetts eHealth Collaborative, a nonprofit health IT advisory and clinical data analytics company. He was also the founding president and CEO of the Indiana Health Information Exchange, a statewide HIE partnered with the Regenstrief Institute, an executive advisor to the investment firm LRV Health, and a fellow at the Berkman Klein Center for Internet and Society at Harvard University. He holds a PhD in political science from the Massachusetts Institute of Technology, a Master of Public Policy from Harvard University, and an AB in political science from Vassar College. Prior to receiving his PhD, he was a presidential management fellow and a senior operations research analyst in the Office of the Secretary of Defense in Washington, D.C., for which he received the Secretary of Defense Meritorious Civilian Service Medal. And then now I'll introduce Dr. Claire Cecile Pierre. Dr. Pierre, oops, sorry about that. I just lost my cheat sheet. Sorry. Give me one moment. So sorry about that. Dr. Pierre is the Associate Chief Medical Officer and Vice President of Community Health at the Brigham and Women's Hospital. She trained in internal medicine at the Cambridge Health Alliance and is board certified in clinical informatics. Dr. Pierre holds decades of experience in the use of technology to improve the quality of care in community health centers. With a career focused on health equity, Dr. Pierre seeks to encourage healthcare innovations that appropriately center and value the expertise of patients and communities. Dr. Pierre also holds decades of experience in global health, focusing on health systems strengthening after disasters. She has previously served as the Chief Medical Officer of Harbor Health Services, a community health network with locations in multiple towns from Boston to the Cape of Massachusetts. She has worked at Partners in Health, the World Bank, and Babson College, and she is an instructor in medicine at Harvard Medical School. All right, so welcome to both of our panelists today. And I think that we're really going to have a conversation for the next few minutes around, around health equity, around data, around public health, and technology. And so, while we have some questions prepared, I think this is really a conversation that the three of us can have together. Is there anything you guys would like to just open with to say hello to the audience?
No, just delighted to be here and very supportive of everything, MassChallenge has been doing, and really excited to be here and look forward to the conversation.
Same here. Looking forward to the conversation and excited and, touched by the number of attendees here. So this is going to be a great open discussion. Looking forward to talking and to hearing the questions.
All right. And, I have seen in public health, in global health, that the public health that I learned about in school or in college, when I was a teenager, was really about measurement of inequity, right? Measurement of disparate impact. And I think we're seeing a real shift in the field. So can you talk about, where we are now relative to where we were then, and what the, what the health equity of the future looks like?
I can
Dr.
start.
Pierre, I'm going to call on you first.
Okay, great. So thank you so much. And I think, also I've also shared your global health perspective and understand the importance of data and measurement. And I often feel like there are buckets of conversations about why we get data in the first place, what it means once we have the data, and what actions we take on them. I think we, for a long time, have collected data for a long time at high costs, lots of probably millions, hundreds of millions of dollars across both community health and health outside of the US, looking at the impact of interventions that were done. And I think now a big part of what we're learning is how to make sure that the data we collect is collected in a way that is meaningful and respectful of the people we're gathering it from. That it's data that we'll take action upon and make sure that we use the data to inform our policies, or the data to inform our clinical decisions or our program interventions, maybe even our funding and investments. And really making sure that our data is not limited to what we believe as whoever it is that's starting the data collection, so that our data collection and the elements we look forward to collecting are defined not just by us, but by those who have the lived experience of whatever we're studying. So I feel like there's a shift, not just in what we're doing with the data that we collect, but even how we are approaching the collection of the data and what else we're missing.
Great.
Sure. Just to add on to that, I mean, we, certainly from the federal government perspective, in particular from the ONC perspective, we've been looking a lot. I mean, we're about, certification or standards in general, technical standards, and that relates to the functionality of electronic health record systems. And it also applies to the data itself. And so we spend a lot of time, thinking about, how do we get better, more accurate, comprehensive, and reliable collection of data for being able to serve the public interest. And we've had an intense focus on health equity related data elements in the, since the administration came in last year. I started on January 20th, so the first day of the administration. And one of the things that we've done is add, for example, to the standard data that's required out of electronic health record systems. We've added data elements that are specifically related to health equity. So SDOH, 4 different data elements to capture different dimensions of social determinants of health, as well as the capture of sexual orientation and gender identity in standardized ways. That adds to the requirements that we already have for EHR systems to capture race, ethnicity, language according to the CDC dataset, which is the most comprehensive, I think, representation of race, ethnicity, language categories. So all of those are about functions and capabilities in EHR systems. And what we don't have a whole lot of authority over, unfortunately, is getting people to use those functions. So that's where we work with our federal partners like CMS and CDC to say, how do we motivate the providers and the users of those systems to capture the data consistently using the capabilities that are available in the EHR. But as Claire pointed out, I think there's a really important piece of this, which is doing it appropriately, doing it in a way that engenders trust, and that doesn't engender fear or intimidation. And so that's a whole part of how we think about it. Again, we're just focused on the capabilities, but we're not blind to the fact that there are other pieces of the ecosystem that are incredibly important to be able to get this more consistently. At the end of the day, why do we want to be able to get that data or get as much of that data more consistently and more comprehensively? First off, to allow provider organizations to be able to take better care of patients with a better view of the factors that may affect a patient's health in a more holistic way. So that's one part. The other is for us to, directly addressing your question, Didi, is how do we have a better ability to measure where there are issues? Because as a health equity expert pointed out to us, if you're not counted, you don't count. So the inability, for example, in the pandemic that we had for a long time, to be able to identify that there were differences in communities in our country with respect to what they were suffering in the pandemic, both with respect to the degree of COVID, the degree of COVID susceptibility that they had, as well as their access to treatment. And access to vaccinations, any other medical countermeasures. All of those things took a long time for us to be able to identify through academic studies and cobbling together different data from different places. We want to be able to create a system that is actually more responsive than that allows us to be able to do those kinds of measurements in a more dynamic way, in a more ongoing way, to be able to identify those things. And the last thing I'll point to is data to be able to inform actionable steps to help mitigate issues before they turn into disparate health outcomes as well.
That is an excellent overview. I mean, New York City, the New York City Department of Health was one of the first institutions to put that data out. And I can just say, working in the pandemic, this was something that through many disasters, but especially in the pandemic, everybody knew it. But having those numbers on a piece of paper and having that transparency to share that piece of paper really transformed resource mobilization. I think it transformed, the ability to get the whole city together, to get other stakeholders together to address the problem. And I think, that does bring up a point. So we talked about, Dr. Peer, you talked about lived experience, right? And, we talk about health as services, right? Like these are services being provided to individuals. At the same time, lived experiences in these systems are often traumatic, right? And so our measurement, it has to interact with that trauma. So where is the line? Like, what are the strategic principles behind, this balance between service and between the collection of data for sort of a greater population level good or a greater institution level good?
It really requires a shift, and it really requires investment and collaboration across. We can't underestimate what was just said about the importance of the data definitions and the data structures, because that alone, as many of you know who have been doing this for a few decades, is shifting and will shift what we collect. I think paired with that is this idea that we find that data is divisive in the US, right? Data can even be subjective depending on who you are. And then for some places and for some people and for some groups, trauma has colored the information and the interaction with data because people have been excluded when their data about themselves were considered. People were excluded because of their race, because of their gender, because of their abilities, because of their sexual orientation, and they know that. They know that they've been treated differently. And so trusting the system and trusting that sharing this data would allow for race explicit or gender explicit decisions that support them requires, I think, a new set of investments in communications around what healthcare has meant in the US. And that would probably start with acknowledgement, recognizing that we have our system as a system. We excluded people, just part of all of the histories. It will need for us to actually be clear about how the data will be used and why it's being collected to rebuild the trust. And to also potentially ask what additional data should be added that influences their health. And that conversation and that will take time, but it's a real, just as much as it took time and investments to make the definitions, we as public health professionals, as clinicians, as community health providers need to do this communication campaign to make sure that people understand why and the importance of it, so that the data can be collected first. And then when interpreted, that's another set of information and gathering and discussions that needs to happen. So I believe communication and structured information about why it's being collected with acknowledgement of how we as a system excluded people would be important.
And Dr. Tripathi, when you're approaching this conversation, it's from multiple different institutions with multiple different considerations. I mean, you talked about maybe within an institution, right? It's hard to get these data collected in the first place. So what's like a big level, big tent kind of strategic principle around the collection of data in a way that both acknowledges and works at the roots of lived experiences of trauma?
Yeah, I mean, I think it's certainly what Claire, and please call me Mickey. Everyone, please call me Mickey. I think it certainly builds on what Claire said, which is about communication. UCLA Health, for example, has been doing a tremendous amount of work in thinking about how do you reach out to patients, proactively reach out to patients about, you're going to be coming into the office. We are actually going to ask you a set of questions about race, ethnicity, language, social determinants of health characteristics. Here's why we are asking those questions. And here's what we're going to do with that information. And trying to build that into sort of the workflow and the conversation so that people can think about it before they come in, so they're not presented with it, shocked by it, and resistant to it. So I think that's certainly a part of it. And I don't think that we should underestimate just the difficulty of that human to human interaction at the front desk. And I'll just give as an example. My mother, I'm here in Massachusetts. Actually, she was a patient at the Brigham. So I'll tell a story about the Brigham. I brought her, 88 years old, brought her to the Brigham. She is, I'm first generation. She's from India. She has a very strong accent. She has dark complexion. She obviously has some interesting, race, ethnicity, language, background information that a front desk person that one would think would trigger in a front desk person, hey, I should ask this question of this person. Anyway, we got back home, we got into the patient gateway, looked at her patient portal. I looked at the category for race and ethnicity language, it said unknown. And it was like, I was with her. There was plenty of time to ask that question. There were lots of cues that would suggest that you might want to ask that question. Person just didn't ask it. And that's not because they're incompetent. It's not because they're ignorant. It's because they're really busy, because maybe it's awkward for them to ask that kind of question. So there's a real human to human thing going on that I think we just need to appreciate. And that's really hard when you are thinking about such a complex provider landscape that we have. So it's one thing, you can put the technology and capabilities, we can say everything we want about communication, but we know there's going to be a huge variation in our ability to do that, which leads to my next point. To your point, Didi, is what's the big thing? I think the big next thing is being able to offer the technologies and the capabilities for patients to be able to enter that information themselves, for them to be able to have the technologies through, and we're working on FHIR APIs that, that require a certain degree of electronic engagement with patients and pushing more and more of that capability into the hands of the patients. So they have apps available to them where they're able to, in advance, say, here is how I'd like to be represented. And then, think about it going forward and all of that embedded in a QR code so that they could actually go to Mass General and then go to Beth Israel Deaconess and then go to Boston Medical Center and just say, here, just scan my QR code. I've already done it once. I want that represented in the same way, regardless of which provider system I go to, and regardless of the different ways that you may capture it in your EHR, I want it expressed in this way.
I would love to add to that I completely agree that I think it's the modalities have to be not just grounded in the health systems trying to collect the data, but also giving the patients, the communities. But it really starts with this conversation. Often the staff in our clinics and in our hospitals, I was at community health centers for a very long time, federally qualified, we accept everyone regardless of ability to pay. Our staff really represents the communities we serve. And now at the Brigham, same thing, a diversity of people. And we've had focus group with staff when we wanted to launch, capturing data around race, ethnicity, or language. And some had discomforts that were, again, a part of that history we've had of excluding. So some didn't want to ask because they thought it would make people feel, especially if they were of representing a group that had been excluded, they thought people would feel targeted. So they avoided the question. They didn't ask because of their own personal experience. Immigration, does that mean, we're going to be excluded or public charge, and this is going to affect our ability to be? So it's so complex. And this is why I'm hoping that we change the culture around data, the culture around collecting. And I love the idea, as Miki's mentioning, of adding tools that allow people to choose and document it themselves, so that we really demystify this idea that data is collected all the time. You can tell us what you want to share and we're open to it. And we promise that when we use it, it will be to have race explicit, gender explicit, whatever it is, ability explicit decision-making that supports your care, to provide you with better care, instead of to exclude you from services. Agreed and completely understood. That example really touches the challenge that we face every day.
Yeah, I've definitely had those experiences with my parents to an extent, certainly with my aunties who maybe weren't as proficient in English as some other patients that were encountered. So I think that for me, this brings up an issue of when we talk about health equity, it's also about the workforce, right? There is the patient on one side, there is the community that's being served on one side, but then there are actual members of those communities on the other side, right? As healthcare providers, as physicians, as the person at the front desk. And so is there a way that data collection can, leverage a more representative workforce, and maybe work in tandem with a lot of efforts to bring diversity to our healthcare workforce?
Yeah, I can start. I mean, I think that it really is, really, really important that our workforce, that everyone has every opportunity they can have, and that our workforce represents the populations that they're serving. And I think that's, that's just really important. People respond better, we know, when they feel like they, have a shared experience, or that the person who they're interacting with is going to understand them. And unfortunately, sometimes that gets grouped into categories that are associated with race or, or whatever, or a sense of socioeconomic status, whatever it is. And, and that means that it's going to be a less effective interaction. So I think that that's a really important, thing for us to keep in mind. We, from ONC we are, again, we have limited levers. But one of the things that that we are doing is we have a $72 million program called the FIT program, Public Health in Informatics and Technology, where we are we've contracted with 10 minority serving institutions or universities that are working with minority serving institutions to train 4,000 plus individuals for public health careers. And so that's working with on curriculum development, for, with those minority serving institutions. And specifically, one of the things that we built in there was not just curriculum development, but the opportunity to provide stipends for them to have internships in the summers, for example, because as we know, if you're from a lower income, family or circumstance, you may not be able to do a free internship, or, you may just have to do what you have to do to make the money that you need. So provided stipends for that, as well as building in requirements for trying to do as much as possible for placement in careers. So we think that's a hugely important part of this, and that we should be providing both opportunities for all of those who are living in this country to be able to participate as fully in all of these all these opportunities that are really important, but also for us as a society to be tapping into all the untapped resource that's just a terrible waste of resource as well. Not that that's not that the efficiency argument is the primary argument, and it's really a moral and ethical one, but I think we just need to recognize too that it's unbelievable that we don't tap into unbelievable resources that we have.
I think, I love this a lot. And I didn't know about the FIT program. What a great workforce development initiative that meets a serious and important need. As I'm listening to you, I think of global health all of a sudden. And I think about when we think of healthcare workforce in the US, we sometimes forget that we're missing a layer that is not investing as much, although it's getting more, there's more interest now. That is the layer that has proximity and trust, which is in some countries, they literally have a complete workforce of community health workers or lay persons whose role it is to help people navigate and reconnect with health systems. And I think the pandemic showed us that. And if there was a way to value that with the right tools to support that, often it requires frequent contacts, trusting conversations, and shared space. But I think with the pandemic, we're learning that technology here can play a role in leveraging that group. So both the idea that maybe we need a public health workforce that has a lot more community health workers and or lay people who have public health and prevention roles, but making sure that those who are in this room designing the next wave of technologies think of that group, as a group that also needs the tools so that maybe they'll help their aunties, their neighbors, or whoever register and decide and choose what the right language is for them, what the right representation would be for them, and also explain the context. I definitely wish that we would pair these initiatives like this whole workforce development. I'm hoping that we can also have the same thing for community health workers or lay people with preventive health requirements.
Right. That's just one small point to add on that, which is there actually is there's a request for information that was put out by the Office of Science and Technology Policy of the White House on strengthening community health through technology. And a bunch of the focus is just what you're talking about, Claire, which is, where is the community health worker layer here? And how do we think about technology enablement for that as well? Unfortunately, the comment period, I was just looking for the deadline. The comment period ended on February 28th, but I'm sure they would still take some comments if you sent them, but more importantly, they should. But I think that they will now be taking those comments, and I think that we should, see sometime in the future, the results of that. So there may be something to build on there. But just to make everyone aware that OSDP and the White House have been thinking about that.
Certainly. It's been actually really great to see the White House's response to the pandemic from, most recently, I guess, in this administration. It's been focused on community health centers in a way that we haven't seen before. In the MGBA network, we have 5 community health centers. We have 2 at the Brigham, and explicit language about making sure that access to vaccination, access to treatment in the departments of public health, ensuring that people realize that the health system in the US, of course, includes the hospitals that we know of, the private clinics that we know of, but also an entire group that serves 1 in 12 people, which are community health centers, and that accept everyone regardless of their ability to pay, and therefore create access for this very group that got excluded for a long time.
Right, and let me just highlight something that Stefan just put in the chat. He corrected me that they've actually extended the comment period. So through March, you have the opportunity to comment on that. I would strongly encourage anyone to take a look at that and please respond. I mean, I can assure you from the federal government side, I didn't appreciate this, just 15 months ago before I joined the federal government, but every single comment on an RFI like that is absolutely read and gone through and taken into account. So the content matters, the quality of the content, as well as the amount of input, really matters as well. And Stefan is our lead working with OSTP as well. So I'm sure he can also be a good conduit for information on that as well.
It's a great conversation. I think, what about like we're talking about like the critical role that the community, right? And that community level advocacy does to increase not just accessibility of healthcare, right? But also acceptability of healthcare. And so what are ways that data systems, especially at this, I love this beautiful vision of like this one integrated data system across healthcare in the United States. But like how, in this perfect system, how do we center and advocate the community level experience?
I've been thinking about this a lot, and I often struggle with the idea that sometimes innovation, research, new technologies, and even new investments are not even based in community organizations, or often not in community health centers. Last year, I tried to survey and see if there were any venture labs, accelerators, incubators, whatever you would want to call them, that would be based out of community organizations and community health centers that would start there, right? Start there because the staff there represents the communities. The patients there would have an opportunity and probably an idea or a challenge, or be themselves, create a team that can pitch an idea. And I found that sometimes people are overwhelmed by the idea that communities are so diverse and so different, and where do you start, and so on and so forth. Yet we're able to start, and we do this all the time for everything else. And so I think the first step is to start seeing communities as a source of expertise, as recognizing that both lived experience and diversity of opinions makes things better, and then truly investing in that, like just as one would for everything else. So I love, and really it was so great to hear about the Pandemic X projects. Thank you, HHSS and MassChallenge, for working on that. And I am hoping that we continue to do more of that, and continue to do some of that based in and grounding in, starting in community health programs, community health centers, community health systems, so that we can recognize the talent there and include them from the design perspective, not just building solutions for them, but having them build solutions too. So really looking forward to that as a next wave.
Yeah, I mean, we would certainly love to do, more, but we're doing a bunch, and certainly want to be able to do more on that side of it, which is resources and trying to motivate and catalyze sort of bottom up and community oriented and community based kind of ideas and innovation. The other side of that I'll just point out is that everything we're doing with respect to policy as it relates to health IT is to create an open industry ecosystem for people like everyone who I think is participating in this meeting today, to be able to innovate and develop on top of it, knowing that you've got an open industry ecosystem with open architectures based on open industry standards, so that you can then have sort of the running room to be able to say, I can see how scalability works. When I'm thinking about my particular solution, I'm not tied to having to do it just with Epic or just doing it just with Athena Health. I can actually see that my little solution here will actually scale across all of those. And so now it's up to me to develop those innovative solutions that are going to scale on that, on that open platform, kind of approach. And so, we've been doing everything we can from an ONC perspective to say, how do we get the industry to a place where that is the core model, and that we're not, sort of in the position of directing the industry in a particular direction, or having the industry, sort of forced into thinking this is one system, like a closed system. The idea is, if it's an open architecture based on open industry standards, it becomes flexible to what develops from the bottom up. And it allows the opportunity, for example, for us to develop, for you to develop, I should say you, everyone here on this, at this meeting, to be able to develop small, lightweight, focused apps that are based on particular needs of particular individuals and their circumstances, allows the ability for them to interact with your medical record information, their claims information, other information, social service information, whatever it is, and then offers them value, in a very lightweight manner, like the whole app ecosystem that works in the rest of, the internet economy and mostly lives outside of healthcare. So we want to be able to bring that to healthcare so that we have, sort of the full spectrum of capabilities. And so you don't have to have, if you're a provider organization and community health center, for example, or a behavioral health center, let's pick a type of setting where there's very important from a health equity perspective, but they didn't benefit from the $40 billion in investment that the federal government made in electronic health records. Their ability to be able to develop lightweight apps that provide the kinds of connectivity and kinds of capabilities that no longer require that you have a full-blown heavy iron EHR system, for example. I think that's another thing that we're trying to motivate as much as we can.
All right, great. And I think we have some questions from our audience here. So let's start looking at these questions. So our first question is, when we talk about the community, how do we involve the ever-growing immigrant population, especially thinking of the next wave of patients coming from Ukraine? How do we engage them as they are a part of the continuously evolving community? And I think that's, I'll share an experience, which is when we were starting our hyperlocal response in New York City, there was a lot of stuff you can get from a person's identification, and it can confirm where they live, especially when there's a geographic aspect to your intervention, et cetera. But, the very act of asking for identification, the very act of asking for health insurance information can be terrifying to a person who is afraid of the public charge, right? Which is, really, even though the public charge is very specific, creates a huge amount of fear that goes much, much beyond what the legislation actually says, in my opinion, intentionally. And so how do we not only involve immigrant communities, but also do it in a way that is safe and is perceived as safe for immigrants? And their networks, I would say.
I'm going to defer to Claire because I will absolutely say I am not an expert in this area.
No, certainly. And so I guess for this would be a lived experience for me, as being born in Haiti and navigating the health system for myself and for my family here, as well as a big part of my work. And this is why I think it requires a full communication campaign with multiple, from federal to public health professionals to local community agencies, working together to make sure the message is clear. But also for the people on this call, it probably requires this new social media approach, because people are getting their health information not from outdoors only and not from us only, right? My mom, who herself was 81 until recently, she would look at WhatsApp and tell me things about the COVID vaccine that I had to counter. I was always behind. So where are we when it comes to public health messaging, and where are we when it comes to preventive health messaging, including the intersection of medical and legal issues for immigrants and so on and so forth? And how do we create these trusted sets of information, but that are distributed using these new digital tools? So across languages and across groups. Someone is studying and knew how to target an 81-year-old Haitian Creole speaking person, right? In the same way that someone is doing the same thing probably for the other populations. So I believe that there is space here for us to not just use our traditional methods of communicating, hair salons, beauty salons, et cetera, but also leveraging technology and recognizing that across age groups, across genders, people are relying more on social media, and there's a role for us here too.
Yeah, I think it's it brings up a really interesting point, because I've actually worked with public health in Ukraine since I did a Fulbright there in 2004, and the active misinformation that's been going on there, certainly very aggressively since 2014, is something that, it's not only happening in the eastern regions, but it has been happening, like we saw measles outbreaks, we saw and we saw a whole bunch of distrust in the health system messaging there, and that messaging doesn't leave when a person leaves the borders of the country. And of course, I think that's a great question. And then maybe Mickey, you have an idea about this, like how can we, the information's going into a system, right? There's data collection. Is there a way that we can amplify, correct information going out using those same systems?
Yeah, I mean, depending on what correct means. So there's correct, there's appropriate. Certainly on the correct side, we believe pretty strongly that patients being able to have access to their information is the best way to having the information be accurate and correct. And so, being able to have their ability to have their eyes on it and be able to have it in convenient ways that are convenient to them is, just critically important to it being able to, accurately represent. And there's lots of different issues there. I mean, from research that's out there, a lot of the errors, and I'll put that in quotes, that patients find in their records are mostly related to demographics. That's not I don't want to overgeneralize that, but a lot of it is related to demographics. That's not my address anymore. That's not my cell phone number. That's not my middle name, or you got my middle initial wrong. So there's a whole bunch of that, and that's and you want that to be accurate, obviously. But there are certainly pieces about medical histories and things like that, to the extent that we still live in a world where sometimes medical histories are really captured by the patient and perhaps misinterpreted, perhaps it's just wrong, perhaps an error gets propagated across the system. So I think there are all of those things, but I don't know if there's any better substitute than the patient themselves being able to identify and correct information. The other thing I would just point to, as I was listening to Claire talk before, is there are probably a ton of lessons, a little bit of change of topic, back to your community-oriented question, which is, we're not real good at this in the US, I think, but which is learning from other countries, and in particular, learning from developing countries. For example, in Africa, there are many countries where they have a huge amount of economic activity on phones that are just based on text, right? You can do a ton of stuff on just a flip phone, because of the limited availability of smartphones, and the limited availability of Wi-Fi access, and a tremendous amount that, and so you think about communities here who don't have access to a smartphone or can't afford a smartphone for whatever reason. We don't think a whole lot about, how do you have capabilities that allow them to do a ton more than we think they can do, right? We just have this expectation that if you don't have a smartphone, you can't do anything. It's like, well, go to Nigeria and look at how much actually gets done via text, a tremendous amount. Not to say that they don't have a huge sort of smartphone market there as well, but I think that there are lots of lessons like that. Before the pandemic, I was doing some work with the Gates Foundation before it was even on the horizon, that was looking at remote diagnostics in Africa and thinking about how we could use Fire-based apps to be able to transmit information from a diagnostic that was done out in the field by a field worker, and then recorded on a smart device, on a smartphone, and then communicated to a central server for analytics and then provided back. Right. And it was kind of a use case that was just like, well, that's a developing world use case. We're not going to have remote diagnostics being a big thing here. And it was probably seven months later that all of a sudden, at-home tests and, all of that became a big deal here and are still a big deal. So I think there's a lot that we can learn from other countries if we're just, if we're open to it. And in particular, I would say for app developers, if you're thinking about, reaching into communities here that are underserved in various ways, I'm gonna, guarantee that there are a ton of lessons from the burgeoning developers in developing countries that could be directly applied to real valuable products and services here.
Right. And it looks like your answers actually align a lot with the questions that are on the chat. There are people asking exactly this: when there are differences in cognition, differences in abilities, differences in access to smartphones, what can we do? And I think the global health world actually is a great place to think about that, and also to think beyond phones, right? Beyond phones, beyond apps, sensors. There are so many things. I know there were teams at MIT looking at how things that you can attach to someone's body can give you a sense of where they're going and how they're doing without you having to be there, voice activated. So there's such a large range. And I think the main point really is here about us stopping for a moment and saying, we were not the only experts. So let's look outside and outside, maybe just outside of ourselves. So whatever we are, is there someone different from us in the room to help us in the design and in the thinking? And then outside of our borders, so we look outside and then making sure that our input is by design starts with a health equity lens. Like there's a health equity checklist before we start our tool or whatever solution we're working on.
I think we have time for one more question before we end. I did want to say, Claire, I noticed you worked with Partners in Health. I also, saw Dr. Paul Farmer as a mentor, and I just wanted to take a moment to remember him and to honor him and express my condolences to you.
Thank you for doing that. For those of you who do know, Dr. Paul Farmer was an anthropologist and a physician, infectious disease specialist who worked in 12 countries with building organizations and coalitions with governments and private sector partners and others. And I worked with him closely for 25 years. I met him as a medical student. And I have to say that he was definitely one of those people who didn't see any boundaries when it came, or limits when it came to the use of technology or the use of new ways or new tools for everyone. And so I think there are principles in his work that you can also refer to. I think his digital health team used an open platform across the world. So many lessons there, and thanks for taking the time to say that. It was a tremendous loss.
All right, so we're gonna just go to our last question to end out this panel. And I think this is a great question to sort of tie up a lot of things that we've been talking about, which is there is a challenge around finding funding in healthcare systems to pay for innovative solutions that reduce health inequities if there isn't hard evidence of a return on investment. If the return on investment for that healthcare system is focused on reducing health inequities and improving patient safety, experience and quality of care, how do healthcare systems fund these solutions? Or even more, fund looking for these solutions?
Yeah, and I think there's, it seems like there's a couple of prongs to that. One is providing more resources directly to provider organizations that serve underserved communities, and through the Medicaid expansion and increased funding for Medicaid, for example. I mean, those are things that in this administration certainly having a big focus on that. The other part of it, I think, is the more value-based purchasing in general, or value-based care in general. I mean, I don't think there's any substitute for when you're in a fee-for-service world. The economics don't work quite in the same way as a world where you specifically have to focus on what's going to be in the best interest of each of the patients, and what are all the things that you might need to invest in to be able to meet patients where they are, and help them get in a better position to be able to access healthcare in a better way, and to be able to think more about wellness again in a way that's going to work for them. So if you just think about the just even in like Medicare Advantage programs, for example, that may not address the entire spectrum of of society that we want, or as fully as we want, but if you just look at the kinds of investments that Medicare Advantage programs make, that don't happen in other parts of sort of the way care is paid for, you start to see that if you put the focus more on value, that people start to make those investments and start to see that I need to think about the patient in a much more comprehensive way than exists in just a fee-for-service world, which is just very short-term thinking.
Couldn't agree more. I completely second that, and that works well for the public side of the financing. I also want to draw attention to the fact that a lot of our healthcare delivery is now being financed by venture capitalists who are launching new methods and new tools. And so encouraging and having open conversations about the role of VC-funded care and the inequities that could be created, as well as the opportunities to not do that, the opportunities to actually address health disparities would be another part of the conversation. So having those two along with value-based care would make a big difference around a new way to finance and what healthcare outcomes mean, what we pay for and what we invest in.
Thank you, Mickey, and thank you, Claire. This was an excellent discussion, and I will pass the mic over to Angel to take us off the stage.
Thank you so much, everyone, for joining. We appreciate the participation and all your great questions. Thank you so much to our amazing moderator, Dr. Didi Ray. Thank you so much for to our panelists, Dr. Miki Tripathi, as well as Dr. Claire. And then if you enjoyed this conversation, please be sure to join us on our second health equity event, which is going to be focused more on health equity and government and what is the role that our local and federal government can play in creating a more equitable healthcare system. You can find the link actually below. But again, thank you so much to everyone for joining. We hope you enjoyed this conversation and hopefully we can continue this further. This is a very important topic that needs not only to be discussed, but continue to be discussed. But again, thank you so much for joining us. I hope you have a wonderful day.